We usually adopt the definition that has been developed by the European Association of Palliative Care, and that especially has been adopted in our work in the EPIC project. The definition runs as follows. I have it here for you. Spirituality is the dynamic dimension of human life that relates to the way persons, individuals, and communities experience, express, and/or seek meaning, purpose, and transcendence, and the way they connect to the moment, to self, to others, to nature, to the significant, and to the sacred. In short, spirituality is the dimension of human life that relates to the experience of meaning, existential meaning, if you like. And I'm quoting from this book by Wilf McSherry, Adam Bowie, and Josephine Attard. I assume this relates to our article in the online journal Religions. You can just Google Kusfeller, Linkners, Religions, and you'll find the open access article. What we mean by that is that we often find that even after a course or training program for nurses in clinical practice, they will usually develop a sense of skills and a certain amount of knowledge and the attitude necessary to engage and provide spiritual care, but that sometimes the conditions on their unit or on the department of their healthcare organizations are not yet favorable for them for providing spiritual care. For instance, it may be that the head nurse of their unit is not in support of spiritual care at all, or for instance, the patient files do not really provide an opportunity to report on patient situations and patient complaints and patient needs in terms of spirituality or worldview, life view, religion. Or, for instance, you want to refer to the hospital chaplain, but you're not really sure where to reach this person. Or you think that your colleagues would benefit from education in the field of spiritual care for patients, but that the education budget of your unit, your ward, maybe even your hospital, your healthcare organization is not sufficient to cover the expenses for education in spiritual care. And that makes that the conditions in which you work, what we call the meso-level, are not favorable for you to develop competence in spiritual care. So the micro level would be the spiritual care that you provide with your team in individual nurse-patient relationships. And the macro level would be the healthcare organization as a whole. But in between, certain employees, managers, administrators, departments have a say in budgets, facilities, the factors that you really need to develop expertise, professionalism, and competence in this area. So that means that one of the things that you have to be aware of as a professional nurse is that spiritual care is not just a matter of your individual competence, but it's also an implementation issue. It also involves innovation in your institution, in your organization. You also have to take care of the facilities that your employer offers to take time to develop the competencies that you need to provide spiritual care. Well, the link nurse is another word for a team champion or a research person in your nursing team. And I am sure that you know the equivalent of such a person in your team of nurses. And of course, as a non-native speaker of English, I'm struggling for finding the right translation for a word that we use in Dutch. But link nurse seems appropriate. So compare, for instance, with my wife, who used to work in a pediatric unit. She used to be the link nurse for breastfeeding. And I have a friend who works in, how do you say this, the polyclinical care, outpatient care with diabetes. And she used to be the link nurse for wound care in the diabetes patient. So in other words, usually in your team, um, you parcel out the work so that not everybody has to be an expert in everything, but that you parcel out these different fields and aspects of your work that one of you will be more expert in than the other, so that this person becomes a resource for you. It becomes um, a dynamic, a force in your team who stimulates that you are aware of the importance of this topic, who makes sure that resources are available to make sure that you have the right knowledge, like tools for intake, or certain questions that you can ask when you think you observe the certain signals that a patient might have that indicate spiritual distress, or that certain skills are practiced, um, perhaps coaching you in applying them in the right way, or um, making a fist, as we say, and standing up for what is necessary in your team. If, for instance, your head nurse or a manager or an administrator keeps on insisting that you don't have time to provide spiritual care. So a link nurse is an ambassador for a certain topic in nursing care, for instance, spiritual care, or a research person who makes sure that the competencies of colleagues are up to standard when it comes to providing spiritual care. So apart from um, having these competencies himself or herself, so like the use of self, use of practice, and the use of profession, a link nurse should also be competent in embedding spiritual care in the um, facilities and conditions that your workplace offers you. He or she should also offer support to colleagues, can also be a go-to person for a chaplain or a physician or for family members. She should also be um, the outpost, so to speak, for collaboration with those who are also involved in offering spiritual care. And she or he should be a role model, an identification figure for the others, so that you can look to others to see how it may be done. And these are extra or added competencies for a link nurse, next to the competencies that every nurse, that every nurse should have to provide spiritual care, at least at a basic level. Well, this is a difficult one for me because we have not really developed a line of research on this specific topic. The article I just mentioned in the journal Religions was based on a project we did in a general hospital, where we also used part of what we call the Scottish Prom on patient satisfaction with chaplaincy. But the outcomes of this evaluation did not really show much. I believe from the top of my head that patient satisfaction with spiritual care by nurses increased by 0.01 or something like that. And the causal relation with what What was behind that is, of course, anybody's guess. So another way would be perhaps to interview um, patients and make clear to them that nurses also have a role in providing spiritual care, and then ask what works best for them. So there are some tools for measuring or evaluating patients' perceptions in a more quantitative way, but we don't have too much experience with that. Then you can interview patients. That might be a very nice student project. We have found that this depends on the unit where you work. Not only because the care that you provide in these units differs from unit to unit. In the pediatric ward, the actions you can take can be different from the oncology ward, for instance, because parents are involved in a pediatric unit in the care that you provide for small children. And in oncology, you can sort of expect that life's big questions, spiritual issues, spiritual distress may surface more easily than in some other units. And in this case, you just have to do, say, a SWOT analysis of what's going on your own unit. You can try to figure out, are my colleagues aware of spiritual needs in the first place? Do they have a beginning of knowledge of what world religions are, for instance, and how they see suffering or health? Also, um, interview techniques like motivational interviewing or conversational techniques like active listening. You can, with the use of a SWOT analysis, you can see if your colleagues are up to the task here, and that will determine whether or not you have certain actions or projects for your department. So, in terms of competencies, this always looks to knowledge, attitudes, and skills. And with a SWOT analysis, you can try to see if your colleagues have those competencies. The article I mentioned was based on a project that I also mentioned, and we evaluated that project after a year. And we found that the link nurses, we offered an educational course to perform that role as link nurse, found it difficult after a year um, to um, to see the purpose of their role and see the actions that they could develop. Um, so we asked them why it was still difficult for them. And the main reason was that they did not feel confident as a professional. There was not enough professional self-confidence, so to speak, especially in how they did or did not feel familiar with the topic of spiritual care. There was a sense of um, not being at home enough to engage patients that they feel might have spiritual issues. They did not know how to ask, and if they asked, they did not know what to do with that information, and they did not feel confident to refer to a chaplain because they did not really know what the task of the chaplain was. So in this evaluation, we discovered that professional self-confidence remained a large issue among the link nurses on those units that we trained, and they did not feel at home with the topic. So it suggests further development of an educational project and perhaps coaching and support for them is still important. An initial course is not enough. I referred to my earlier answer that spiritual care also has a an aspect of an implementation issue. You should also look at what the organization needs in terms of an innovation of ways of working and the preconditions and facilities. They also said that time and support by their superiors was also an issue, but also the culture in that team. It, when meeting with a lot of resistance or ignorance, they found it difficult to work in this role as a learner, and that makes sense. So it's also important to look at what your team members, your colleagues think about spiritual care, your own role, their role, the needs of patients, and so on. So those actions you can take, an analysis of what's going on. What do our patients need? Do my colleagues have what is needed? But also we know from an evaluation that it remains an issue um, of the confidence to take the initiative, to be an ambassador, because if nobody is going to uh, take on this responsibility, and you as a nurse are not going to take this responsibility, then nobody will. Thank you for your time, and I hope this helps.